Assalamu alaikum. The long clinical consultation day. First scenario, Mr. Sami, 65 years old, with a history of tremors. Please take history, examine him, and address his concerns. Ready?
Yes, Dr. Basim, but sorry, you are speaking with Mr. Ahmed, the son of Mr. Sami.
Okay, good. So you are speaking to his son, Dr. Sar.
Yes.
Okay.
To train about the exam, Dr. Sar. Okay.
Okay. Hello.
Yes, hello, doctor.
I'm Dr. Auda Karim. I'm one of the doctor covering the session today. May I confirm that you are Mr. Ahmed, a son of Mr. Sami, 65 years old?
Yes, doctor. Yes.
Are you the next of kin of Mr. Sami?
Yes.
Okay, so we are here to talk regarding the health condition of your father. Okay, and after that, you want to examine him, and we can address your concern. Is that okay with you?
Yes, doctor. Thank you very much.
Okay, so could you please tell me what brought your father here today?
Yes, doctor. I think my father has shaking. So he can't. It is impacting his life. So I came to the hospital to know what is going on with my father.
When it started for him exactly?
Yes, it started, I think, doctor, since 6 months.
Since 6 months. Is
Yes.
it first time or you have it before?
No, doctor. It is the first time since it started. I think
Okay.
it is worsening.
I'm sorry for that. I will try to help him. Okay, this shakiness of his hand, is it in one hand or in both hands?
I think it is in the both hand, but it is more in the right hand.
Okay. Okay. So anything to worsen it, this shakiness?
Sorry, worsen it. I don't know, doctor.
Yeah, like with exertion, with stress.
I think, doctor, yes, it is increased with exertion.
Anything to improve it, like when he drink alcohol?
My dad didn't drink alcohol, doctor.
This shakiness of the hand, it may occur at rest or when
Yes, I said.
yeah,
Yes,
or
doctor.
when he about to reach the object or without stretching of his hand?
I think it is during rest, doctor, more.
During the rest more.
Yes,
okay.
doctor.
So apart from this shakiness of the hand, is there any shakiness of other part of his body, like the head?
No, doctor, I don't think so.
Okay. So yes, is there any slowness of his movement?
Yes, doctor, sometimes. Yes, you are right.
Any stiffness in his limb?
Yes, doctor, might be.
Okay. So apart from that, is there any vision problem?
Vision? No, I don't think so, doctor.
Any double vision?
No.
Okay. Any loss of balance?
Loss of balance? No, doctor.
Okay. Yes. Any fits before?
Fits, no, but he fall one time, doctor.
Okay. I'm sorry for that. Okay. When he fall?
Yes,
Exactly.
Yes, he was in the supermarket, and I didn't recognize him. I turned to him. I see he was fall in the ground.
Did he injure himself?
No, doctor.
Okay. So any weakness anywhere in his body?
I don't know, doctor.
Any alter in sensation?
No, doctor.
Okay. Any memory problem?
Nobody know.
Okay. Did your father he see object which is not find with other?
No, doctor. I don't think so.
Okay. Any sleep disturbance or a sleep problem?
No.
Any mood problem?
No.
Okay. So does your father he has any difficulty when he want to go upstairs or downstairs?
No, doctor.
Okay. Is there any high body temperature?
No.
Any neck stiffness?
No.
Any weight change?
No, doctor.
Any lump or bump in his body?
No.
Anyone comment for him he become better than usual?
No, doctor. No
Any
one
tiredness?
said. No.
Any weather preference?
No.
Okay, so is there any medical background I should be aware of?
Yes, doctor. My father has high blood pressure. He is in captopril, 10 milligram, and also he has high blood sugar on insulin.
Okay, so regarding his high blood pressure, so is it controlled well?
Yes, doctor. I think so.
He adherent to his medications?
Yes, doctor.
Regarding his blood sugar, when's the last test, which you called accumulated blood sugar reading in the last 3 months?
Yes, doctor. It was 6.8.
Okay, so what medication he took?
Insulin, doctor.
Okay, so is there any high cholesterol in his blood?
Yes, doctor. He is anti-fat medication.
Okay, okay, so your father, does he smoke?
Yes, doctor.
Okay, how many cigarettes and since how long?
Yes, I think, doctor, 15 cigarette
Mhm.
per 30 years.
Okay, so we advise him after I will end the session, we advise him to stop smoking because the smoking is hard for your health. Is that okay?
Yes, doctor. Thank you very much.
Okay. So is there any surgical procedure before?
No,
Okay. I'm sorry for asking this question. Any recreational medicine?
no,
Okay. Any chest pain?
no, doctor.
Any shortness of breath?
No,
Any awareness of his heartbeat?
no.
Any change in his bowel habit?
What is the meaning of change, doctor?
Any change of his bowel habit?
Like what?
Like hard motion, loose motion?
No, doctor.
Any change in his water work?
Like what, doctor?
Regarding the change in the frequency, the amount, any burning when
No,
he bathing his water work?
no, doctor. I don't
Any
think so.
frothiness in his water work?
No, doctor.
Any joint pain?
No,
Any skin rash?
no.
Okay. Any family history of similar condition?
No, doctor.
Any
I
family
don't.
history of not?
No, doctor.
Okay. So what he do for living?
Yes, he is retired, doctor.
Okay. So does your father he drive?
Yes, doctor.
He's able to maintain his driving with this shakiness?
Yes, doctor. He can drive.
Okay. So may I examine him now?
Yes, doctor.
Okay. So yeah, I need the vital chart of the patient.
Yes, blood pressure normal and the blood sugar normal. Yes.
Okay. I'm sorry for yeah. I want to ask questions. If your father has any dizziness when he changed his position from sitting to standing?
No, doctor.
Okay. So I want to check the blood pressure sitting and standing.
Yes. No posture hypotension.
Okay. So yes. I want to start examining the hand.
Okay.
I will yeah. I will look for the tremor. Is it in one hand or in both hand now?
Yes, in the right hand more than the left hand.
Okay. Is it resting?
Yes, in the right hand it is in the resting, and the left hand it is slight tremors.
Okay. Bell tremor. Bell rolling.
Yes, doctor. Bell rolling tremors.
Okay.
Tell me.
Yeah. Please, yeah, I would like to check for bradykinesia.
Okay. How can
Okay.
we do?
Can you move your thumb around your other fingers and touch it, please?
Like
Can you do like this? Yeah.
like counting? Okay. He can
Yes,
do.
counting.
He do it slowly.
Mm-hmm. Okay. So yes, regarding synkinesia, just I want to yes, please tap the other hand
Which
in your
hand?
bed.
The right hand or left hand?
The left hand.
Yes. Okay. I tap in my leg now.
Okay. The tremor in the right hand isn't increased.
Yes, doctor. It is increased.
Okay. So I want to examine pronatal drift for this patient.
Okay. Bronto drift. Okay. Tell me the instruction.
Negative or positive?
Okay.
Okay, please, yeah. can you do like this? I mean, can you face your both palm up and close
Yes.
your eyes, please?
Yes, doctor, I closed. No, it is the normal.
Okay, I want to do upper limb neurological examinations to also to check the tone around the elbow.
Yes,
If
around the
there's any
elbow.
rigidity,
Yes, it is rigidity.
lead pipe
Yes, it is lead by rigidity. Yes.
around the wrist, cogwheel rigidity.
Yes, there is cogwheel.
Okay, so I'm going to examine the vision. If there is any, the visual acuity and the
Okay.
H-shape movement.
Okay, tell me the instruction, Dr. Sarah.
Yes, okay. Regarding the visual acuity by counting finger counting test, please cover your right eye.
Yes, I cover it now.
Did you see it?
Yes, doctor, I can see.
Okay, the left eye, please.
Yes, doctor, I can see also.
Okay, thank you. Okay,
Okay.
so please follow my finger wherever it goes. If you are
Okay.
see double or bad, let me know. Okay, H-shape movement.
Okay, it's shape. Okay. Now
If
you
there's
move.
any nystagmus or
No, doctor.
okay,
Nystagmus,
I
no.
would like to check for the vertical gaze. I will bring my fingers up and down.
Okay, I can see.
Okay. Okay. So just over fundoscopy because this
Doctor.
patient diabetes hypertension. Yes.
Yes, okay. No need, doctor.
Okay. So I would like to check his name. Please give me your full name
Yes,
regarding the speech.
yes, Sami Ahmed.
Okay. Low monotonous speech. Okay.
Yes,
Also, I would like please write for me here in this paper. Regarding the writing, is there any microgravia?
doctor, I am now writing. Yes, it is micrographia.
Okay, so I would like to do for corticobasal degeneration.
Yes,
I will give you substance in your hands. Please close your eyes and tell me what is.
yes, doctor, it is the key.
Okay, so I would like to check the lower limb neurological examination for power and reflex. And please, are you steady at all? Please walk for me. I will see his gait.
Yes, okay, to examine the lower limb or gait.
After the lower limb, just I will check the power and the reflex, plantar reflex.
Okay, doctor, it is normal. And now the gait, it is short shuffling gait.
Okay. So I would like to complete my examination by doing mini mental state examination.
Okay.
Yes. Okay. Also, I would like to do urine dipstick for proteinuria, and I would like to check the blood sugar also beside.
Yes, very good. Okay. Okay, doctor, 2 minutes
Okay.
remaining. 2 minutes remaining.
Okay. So I will go back to his son. Yeah. So
Okay.
Mr. Ahmed, what is your concern?
Yes, doctor, what he have?
Yes, Mr. Ahmed, actually, after I ask you some question and after examining him, your father have been troubled with this shakiness of his hand
2 minutes
as a related
left.
condition which is called Parkinson disease, in which there is a damage in specific cell in the brain responsible for the secretion to special proteins, which is called dopamine. That is why he division from this protein result from this manifestation such as having now. So what we are going to do now, we are going to run for him some blood tests and some scanning. And also we need to be involve a group of specialists which include the brain doctor or the nerve doctor, occupational therapist, and physiotherapist, specialized staff nurse, and other specialties according to his need. Do you have another concern for me?
Yes, doctor, it is treatable condition.
Yes, Mr. Ahmed. After we confirm his diagnosis, there is medications to replace this deficiency protein, and also there is another option like surgical options if his condition needs that.
Okay, doctor.
Okay.
Okay.
Any
Yes, it is serious condition, doctor.
yes, Mr. Ahmed, I'm sorry to tell you that yes, if not controllable well, it can be serious because it can be progressive and advanced with age.
Okay, doctor. So, okay, doctor. Can I ask you, do you will admit my father in the hospital?
No, now your father, he didn't, to be admitted here in the hospital. Just we need to be evaluated.
Okay, doctor, thank you.
Okay.
Okay, well done, Dr. Sarah. I examine our question. Okay, tell me your positive signs.
Okay, I have asked to examine Mr. Sam, 65 years old, who presented with a hand tremor in both of his hands, but with mainly worse in the right hand.
Yes.
Yes. Yeah, the tremor is a resting tremor, birolli. Okay. With bradykinesia and synkinesia, and also there is rigidity at the elbow, which is the lead by rigidity, and at the wrist, which is the cogwheel rigidity. Apart from that, yes, this patient he has expressionless face. Yes, and also I didn't find any other symptom going with the Parkinson plus syndrome.
Yes.
Yeah.
Okay.
Regarding his speech, it monotonous speech, slow monotonous speech. There is microgravia, and also regarding his walk, his gait is short shifting, frustrating gait.
Yes, doctor. Okay, thank you. Okay, what is your investigation to this patient and how to diagnose him?
Yes, regarding the investigation, usually the Parkinson disease, it is clinical diagnosis, but we need to do a SPECT scan just to differentiate between the Parkinson and the essential tremor.
Okay. Any other investigation?
Yeah, I will do other investigation to exclude other causes like vascular Parkinsonism. Parkinson, I will do diabetic screening in these patients and lipid also profile.
Okay, doctor, what is the treatment
Yes.
of this patient? Yes, and the electrolytes. Okay, what is the treatment of this patient?
The treatment in this patient, non-pharmacological education and counseling about his condition, NDT approach. Okay. Neurologist, occupational therapist, social worker, specialized nurse. Okay. Also, we need to control his diabetes. Yeah, already diabetes control. Okay. Replacement therapy. I will give him dopaminergic, like levodopa, carbidopa, and methyltransferase inhibitor, and also monoamine oxidase inhibitor like sligine. Or also surgical option like deep brain stimulation surgery or lateral salamectomy. Okay.
Okay. Okay, doctor. Sorry, I forget, Dr. Sarah. What is the differential diagnosis?
Yes, the differential diagnosis Parkinson disease.
Yes.
In view of his age, I didn't find any other cause of Parkinson in this patient, so I will put idiopathic Parkinson disease in the top of my differential.
Okay.
Essential tremor, but again, it's that no family history, and
Yes.
also cerebellum syndrome, but yeah, but again, it's that no cerebellum.
You didn't
Symptom
check coordination.
just upper limb neurological examination.
Okay, you check cerebellar symptoms, syndrome?
Yes,
Sorry.
the coordination within the upper limb, and also H shape for nystagmus.
Yes, doctor. Okay. Okay, can you tell me what is the Parkinson's plus syndrome?
Okay.
The types?
Okay, Parkinson plus Okay, there is a low body dementia and corticobasal degeneration, supranuclear gas of palsy. Yeah, other causes of Parkinson like vascular, post-trauma, post-tumor, and drug medications.
Yes, okay. Okay, doctor.
And multiple
So,
system atrophy also, Shea-Diriger syndrome.
Shadrach, okay. So what is the cause of,
Diriger.
okay, what do you think about the cause of Parkinsonism in this patient?
Yeah, because now he's diabetes and hypertension because he's having ischemic risk factor. So I not to exclude the vascular, but I will put idiopathic.
Yes, doctor. Yes. And about the trauma, did you ask?
No, I forgot it.
Okay, Dr. Sarah, thank you very much. I'm finished.
No, thank you.
Okay.
Yes. Okay, Dr. Mahmoud, you can comment now.
Yes, you actually, Dr. Sarah did it very well, very well. But I have only one point that you assume that the patient has shaking of the hand. So you ask, you have shaking. Okay, who is the shaking? He will tell you in the hand. Yeah, okay, any other shaking? Like you ask it later, but first don't assume that the patient only have shaking of the hand. May have any shaking in head, in the hand. That is my point. That is the first. You started well. It is the first time when any previous attack and onset course duration. You know the case when you ask about the patient during rest or during catching object or before you reach the object. So it is during rest. And I think you have like any improving factor, not alcohol only, but during sleep. All tremors hidden during sleep. Okay, then you confirm the Parkinsonism by any that shaking hand, slowness of the movement, stiffness in the limb. Also, you have during CNS analysis that you notice that any dropping of the saliva like that. He hasn't any dropping of saliva, but it is a good question. And then you have to exclude cerebellar symptoms by also CNS analysis, any loss of balance, any unsteadiness. You did it very well. And then you have to exclude Parkinson's plus by systematic review. You have any dizziness in standing from sitting position. You have any loss of control of your water work and your bowel. That's why I ask you what do you mean about any bowel change and water work change. I was waiting for any loss of control to exclude Lewy body dementia. Okay, and exclude about the vision, and also what other? Yes, and exclude also during CNS analysis any weakness, any numbness, to exclude any stroke. But you have to exclude any trauma. Very good question about any neck stiffness, to exclude any infection. And examination was very good, very good about the gait. You remember the gait of the patient, and you examine. But I think Dr. Sarah didn't examine the coordination because you have to examine finger
Yes,
to
I will
nose.
involve it in the upper limb neurological examination.
Yes, that's why I wanted to
So
do.
I will examine.
Yes, that's I told you. Give me the instruction to see if you will forget the coordination or not, and you forget the
Okay.
coordination. So you have to do yes, finger to nose test and this diadokinesia. And then in the lower limb also, I think also it should be done that you check any stiffness, you check also the coordination in the lower limb and the Babinski sign, and then finish it by I want to check your gait, please. Okay, that is in the history and in examination, and you Parkinsonism, you all concern you very good. You answer it very good, and physical signs about with the examiner. You tell all the physical signs, but frequent blinking and yes, and didn't tell me that. Okay, differential diagnosis was very good. Parkinsonism, benign essential tremors. You asked about the family history already. It was very good. And the cerebellar symptoms you put in the differential diagnosis without checking it during history, or yes, you check it during history, but you didn't check it during examination. Investigation, the diagnosis is clinical, but yes, we have to do SPECT scan, single photon electronic CT to differentiate it between Parkin plus. The treatment, it will be non-pharmacological. Don't forget salt team in the Parkinsonism. Don't forget that salt team. Medical, it will be by for tremors. That is the main complaint of the patient. Tremors will give him anticholinergic drugs. For bradykinesia, we will give him dopamine agonist, levodopa plus carbidopa, and there is option of treatment, of surgical treatment. It was deep brain stimulation. But you did it very well. Well done, all satisfactory. But I think in I don't know, communication, no. Okay, well done, Dr. Sarah. Thanks, Dr. Sarah. Thanks, Dr. Basil.
Okay, thank you, Dr. Mahmoud. Well done, Dr. Sarah.
Thank
Yes,
you.
I think Dr. Mahmoud also covered the whole topic of Parkinson. It's very important topic, either short as a neuro, it can come, or even as a long clinical consultation. So you don't know which is lucky to have it in your exam, either short or long. But both of them, you can get a good mark as a differential and clinical examination. Why? The examination will be targeted to the Parkinson itself, the triad of Parkinson, in the form of bradykinesia, rigidity, and tremors, resting tremor. This is the cornerstone of Parkinson. You have to examine them. Then confirm the Parkinson, synkinesia, and other finding, the type of rigidity, lead pipe or cogwheel at the wrist, lead pipe at the elbow. And the time now to roll out the other causes of Parkinson plus. The vascular cause you roll out by pronator drift. You will do the blood pressure sitting, standing. So either history taking, you confirm, like posture hypotension, or while examining the patient, you can offer blood pressure sitting, standing to rule out multi-system atrophy. Again, in the history, you rule out progressive supranuclear palsy by asking any difficulty while you are going down the stairs. And during examination, you have to do the H shape for down gaze. And the basal degeneration, you can draw on his hand or touch, put him something to recognize it while closing the eyes. I think these are the examination in summary for Parkinson and Parkinson plus. Lewy body dementia, don't forget about ask about the hallucination, any visual hallucination, or does he see things which is not real? Okay. Always forget whenever the patient, when to start the medical pharmacological option, whenever is patient is having disabled symptoms. Okay, so either he's not able to do his motor because of the tremors, anticholinergic, or you can start dopamine agonist, carbidopa, levodopa, and the other option, monoamino oxidase inhibitor, COMT inhibitor, and anticholinergic already mentioned. Salty, multidisciplinary. It's you can talk a lot in every question according to the case and according to the examiner target, what he wants you to mention and what he wants you to examine. Of course, you have to do cerebellar examination, symptoms, regarding the symptoms as intention tremor to rule it out, and also the nystagmus while doing the H shape. That's it. I think Dr. Sarah covered all finding as a history taking and examination, apart from cerebellar examination. Anyone want to ask or to add something important we miss, me and Sarah and Mahmoud?
Thank you, Dr. Basim. Thank you very much. Thank you.
Okay. Write your case, Dr. Sarah or Dr. Mahmoud.
Okay.
I will try to read it.
Dr. Bassam.
Yes, sure, Dr. Gabriel.
Yeah, sorry, just to add a little, just important information. I think there's a test, a bedside tool test that one could use that is called the Archimedean spiral that will help to differentiate between resting tremor and Parkinsonism tremor and that of essential tremors. They just make a spiral on the piece of paper, ask the patient to copy it. That of the patient will be clumsy. I mean, they will be crowded. The spiral lines will be crowded, unlike that of the examiner or the doctor himself will be well spaced out. Just a spiral drawing. It's called the Archimedean spiral or Archimedes spiral.
You mean outstretched hand?
No, to a pen and a biro or a pen and a paper, ask the person to copy a spiral figure. If the patient does that, he will not be able to do it well. The lines of the spiral will be crowded together or they will be zigzag.
Okay, zigzag. Yeah. So he cannot copy the movement. Yes.
Exactly. It's called Archimedes spiral.
Oh, okay. Please write it yes in the chat box, Dr. Gabriel, also to be more aware about it. The name of the technique. But I heard about the zigzag movement, so he cannot follow because of the essential term. Not only that, by the way, you can also notice the head nodding. Head nodding will be with essential terms. Okay. Yeah, the drug history is very important here. Medication list. Please show me your father medication list. Check it drug by drug. It might be drug induced. Whatever. The drug induced will be bilaterally, but the Parkinson will be idiopathic. The idiopathic type, I mean, it's symmetrical, supposed to be asymmetrical. What are the medication can cause Parkinson or the tremors?
Metoclopramide and chlorpromazine.
Yes. And antipsychotic?
Atypical antipsychotics?
Yes,
Exactly. Atypical antipsychotic, risperidone. Already mentioned haloperidol, yes. So antipsychotic and the metoclopramide antiemetic. What else? Anti-epileptic. Or sorry, not anti-epileptic, the dopamine antagonist. Right, like domperidone. The same, it's is anti-emetic, but you have to mention dopamine antagonist. Okay, along with the antipsychotic, the atypical one, and the last two is the antiemetic we already mentioned, metoclopramide, haloperidol. Okay, but you have to check his medication from the list. Check every medication because you might put a differential, it's drug induced, for any Parkinson patient or any even seizure patient. Any patient is having rash, you can put drug induced. It's one of the important differential, either to get it from the list or from the history. But be sure you have to do a look to his medication list. Okay, it might be the clue or it might be the differential. Sodium valproate, anti-epileptic, yes, Dr. Nada. I remember also one of the anti-epileptic can cause. Archimedine spiral. Yeah, this is Dr. Gabriel. Okay. Miss Mona, your patient, Dr. Mahmoud. Miss Mona, 60 years old, present with confusion. So it's a good topic to be CNS case today. System. Take history from the daughter, Sarah. Let's go to the differential. Lewy body, Dr. Nada. Lewy body dementia is not apart from Parkinson plus. It's one of the cause of Parkinson and dementia. Yes, it's not, of course. It's one of the differential. Parkinson plus multisystem atrophy, progressive renal palsy, corticobasal degeneration. the other differential post-radiation, medication, infiltration, toxin, other differential kinetic and positional. Yes, so don't give differential of kinetic with the resting. So if he asked you about the tremors in this patient as a differential, you have to say the Parkinson, the all types of Parkinson, and the other types of Parkinson like Parkinson plus. If he asks you what other tremors you know, doctor, you can say attention tremors with the cerebellar syndrome, or essential tremors, or positional, or fine, or flapping. Okay, so it's related to the question of the examiner, what he need exactly. But please, in the top of your differential, Parkinson, Parkinson plus. Okay. Dr. Nada, also good differential, vascular cause, post-trauma, normal pressure, hydrocephalus. I don't think it causes tremors. It causes dementia, urinary incontinence, and walking difficulty. I don't think it causes tremors. Okay, Dr. Nada. Parkinson, Dr. Gabriel Parkinson, Parkinson plus, drug-induced, hereditary, CNS diagnosed, CNS differential. Dr. Ayula, Parkinson, idiopathic Parkinson, essential tremor, cerebellar, drug-induced hyperthyroidism. Yes, again, it's according to the tremors, either fine or flapping, or our case to date, resting or kinetic or tension tremor. Wilson disease, again, another differential, Dr. Henry, but again, it was for the tremor itself, not as a Parkinson or resting tremors. Hyperthyroidism, okay, Friedreich ataxia, Huntington chorea. So it sounds that Huntington chorea will be abnormal movement rather than tremors. Okay, involuntary abnormal movement. I don't think it's a tremor. Regarding the Huntington. Anyway, if you have abnormal movement, you can put this big differential. But if you have tremors, you have to specify what the type after analysis of the complaint, the relevant system, and the differential. While you are analyzing the relevant system, which is the CNS, in every question, try to roll out or roll in what is the possible Parkinson you have. Is it Parkinson, idiopathic, or plus, and which type of plus you have? Okay, sodium valproate again. Thank you, Dr. Nada. Anyone want to add comment before moving to the next scenario?
Yes, Dr. Basim. In essential tremors, I think the patient must be younger than that.
Yeah.
45.
It will be younger patient with family history.
And the family history.
And
Okay.
alcohol. Improve it.
Okay.
Okay, it might be the case, by the way, but you have to rule out the other tremors. Okay, tremor, trauma, stroke, and all the things. You have to rule it out and to confirm this is not Parkinson. How to show the examiner that you are ruling out Parkinson? By the questions about the Parkinson triad. The resting and any slowing of his movement, and the gait,
And the stiffness or
and
rigidity.
rigidity, yes, or rigidity or stiffness. So please show the examiner that I rolled it out totally by this question. Okay,
Mhm.
ready to start? Anyone want to comment before starting the second scenario? Again,
Basim,
yes, Dr.
one-
Marwa, yes.
yes. Doctor, this is one query regarding Wilson disease. I will ask, I mean, it will be secondary cause of Parkinsonism or tremors. I mean, when I should ask about Wilson, this question, yani.
Perfect. By the way, Wilson can be presented either Parkinson or as a chorea, right? So according to the complaint, you will know is it Parkinson as a tremors or it is abnormal movement like chorea. You can put it as a differential in both, but you will have family history of the same condition or liver condition. But according to the abnormal movement, you can put it either with Parkinson. Yes, it can lead to Parkinson, Wilson, and it can lead to chorea. So it's possible in both as a differential. But again, the patient will be younger and he will be with family history. Okay, in the examination, you can say, I would like to examine his liver whenever you rolled out all the causes and you have young patient. So to narrow it more, you can say the family history, it can be conclusive for the Wilson disease as well as for essential tremors. As family history, not confined to the type of tremor. I'm talking about tremors in younger patients. Or drug-induced. Idiopathic usually comes at the 60s, right? 50, 55 plus, but it's not younger than this. But drug-induced can be early or younger age. The Wilson will be younger. Essential tremor will be younger, along with the family history, of course. Okay, Huntington chorea, but as a chorea, not as a tremor. Or thyroid disease, tremors, but as also fine tremors. Or flapping tremors in young patient. You can talk about polycystic with end-stage renal disease. So it's wide differential, but again, it depends on your scenario, how it will be drive. Is it tremors with the movement, with the rest? So your approach will show and it will narrow your differential according to the map while you are taking history. But you have to put all this under your differential according to the major tremor or the name of the disease. Tremor or abnormal movement, shakiness. After analysis, you can narrow your differential. Clear, Dr. Marwa?
Yes, doctor, clear, thank you.
Okay, most welcome. Dr. Rabia, if she's with us as a neurologist, she can add any comment. I think. Are you with us, Dr. Rabia? Okay. She's not present. We can start the second scenario. Dr. Mahmoud ready?
Yes, Dr. Basim, I'm ready.
Yes, here you go.
Okay, good evening. I'm Dr. Mahmoud, doctor in the clinic today. Let me confirm you are Mrs. Sar, daughter of Miss Mona, 60 years old.
Yes, doctor.
Okay, Mrs. Sarah, we are here to discuss about Mr. Mona condition. Is it okay with you?
Okay.
Okay, Mrs. Sarah, how can I help you today?
Yes, doctor. Because of my mother, she
Mhm.
has confusion since morning today. So I will bring her here to hospital.
Okay, Mrs. Sarah, what do you mean about confusion? Does he lose his consciousness or just dizzy?
Yes, doctor. Yes, there is a loss of consciousness.
This consciousness. When it started
Yeah.
exactly? Since morning?
Yes.
What will she doing while she have this confusion?
Just I think before the breakfast,
Yes.
she's preparing for breakfast for today, and
Okay.
just she feel confused. Yeah.
Okay. Did he lose his consciousness?
Just she feel confused, doctor.
Confused. Okay. Did he have any?
Yeah.
Okay. Before
You
that,
can say that she has some disturbance in her consciousness at that time.
I'm sorry for that, Mrs. Sarah. Mrs. Sarah, did he have any before that any abnormal smell or abnormal vision?
Never.
Did she have any racing heart or chest pain?
No, doctor.
Okay. Does she have any shaking of the hand or sweating?
No,
Okay.
I didn't say.
Okay. For how long it continues, Mrs. Sarah?
Yes, it continued for her like hours. I think 3 hours.
3 hours.
Yeah.
Did he? Okay. During this 3 hour, does she has any shaking of the body?
No.
Did you measure her blood sugar or blood pressure during this attack?
Yes, doctor.
Okay.
Because my mother, she's has high blood sugar. That is why I check it. But I find it normal, doctor.
It was normal. For how long she
Yes.
has high blood sugar?
Yeah, since long time, doctor. I think more than 5 years.
What medication she are on?
Yeah, she took metformin and
Mhm.
dimicron.
Okay. Are she compliant on the medication?
Yes, doctor.
Okay. Okay. Tell me, Miss Sarah, how the attack and did she take any sugar? Did he take any medication during this attack?
No, doctor.
Okay. Did he recover fully conscious?
Yes, doctor. Now she recovered completely.
Yes. Did she have any weakness or numbness
No,
or mouse deviation?
no,
Okay. Any loss of balance, like
no.
unsteady? Okay, very good. Apart from that, did she have any history of headache? Or before that, she complained of headache?
Yes, doctor. My mother, she has a headache before.
Mm-hmm.
I think she diagnosed her as having migraine.
Migraine. When was the last attack of migraine?
Yeah, before 3 months. Yeah, because yeah, it control.
Is control. What medication she on migraine?
Yeah. She
What
took some medications.
did you know the medication, Miss Sarah?
I think propanol. I didn't sure. Yeah, exactly.
She take propanol daily.
Yes.
Okay. Miss Sarah, what about her vision? Any problem in her vision, like blurring vision or double vision?
No.
Okay. What about her memory? Any change in the memory?
No, doctor, never. Because before this, but I'm noticing that during this attack,
Mm-hmm.
yeah, I think she lost her recent memory.
Okay. Okay. Does she know you during the attack? She know
Yes,
like
yes, she know me, doctor. Yeah, she know me. Yeah.
she was still repeating repeat same question during this attack.
Yes, doctor. Yes. When I
Oh,
bring her here in the hospital, yeah.
okay. During this attack, she was know you. She was know you are her daughter.
Yes, doctor.
Okay, she can recall the old event during this attack.
And yeah, I think yes.
Okay. Can I ask you any history of high blood temperature?
No.
Any tiredness?
No.
Okay. Any weight changes recently?
No.
Any lumps or bumps on her body?
No.
Does she have any night sweat or sweating during the day?
No.
Okay. Does she have any tummy pain or loose motion recently?
No.
Any throwing up?
No.
Okay. Any change in her water work, like increase the amount or flossy or pain while passing her water work?
No.
Okay. Does she have any joint pain?
No.
Any back pain?
No.
Any neck stiffness?
No.
Any rash in her body?
No.
Okay, can I know what did she have any long-standing disease other than high blood sugar, any high blood pressure, or any increased fats?
Yes, doctor. Apart from the high blood sugar, yes,
Mm-hmm.
and migraine, yes. Also, she has high blood pressure.
Okay, what medication she are on?
Amlodipine,
Amlodipine. Do you know the course, the dose? Sorry,
10 milligram.
10 milligram. Okay. Are she compliant on the medication?
Yes, doctor.
Any other medication she taken?
No.
Any over-the-counter drugs?
No.
Any herbal medication?
No.
Sorry about that. Any illicit drugs that she taken?
No.
Any drug allergy?
No.
Okay. Does she have does Mrs. Mona have any family history of any disease?
No.
Okay, what do you do here for living?
Yeah, just she housewife, doctor.
How much is symptoms impact in here daily activity?
Actually, because it appeared for her today.
Mm-hmm. Mm-hmm.
Yeah.
Mm-hmm. Mm-hmm. I'm sorry for that, Mrs. Sarah. I hope to diagnose here and give her suitable treatment. Okay, does she smoke?
Yes, doctor.
How many cigarettes and for how long?
Yeah, 5 cigarette, doctor. Since
I
2
will-
years ago.
I strongly
Mhm.
advise here Mrs. Sarah to stop smoking. I will sit with her and advise her. Does she drink alcohol?
No.
Okay, does she drive?
Yes, doctor.
Okay, I will advise here to stop driving at the time being till we diagnose her and give her suitable treatment. It's okay.
Okay.
Okay, Miss Sarah, I would like to examine your mother, and during examination, I would like to ask you some question.
Okay.
So, Mrs. Mona, now I am with Miss Mona. Miss Mona, do you know where you are now?
Yes, doctor. She's
Uh,
aware now.
Okay, I want to examine you. If you feel any pain, please tell me. It's okay with you, Miss Mona. Miss Mona, can you?
Okay.
Okay, can I see your hand, please?
Okay.
Okay, I will see her hand. If there is any leukonychia, then I want the observation chart of the patient. I want to check her blood sugar. I want to check blood pressure sitting and standing. Um,
Mhm.
um, yes. Okay. Any change in blood
Normal.
pressure sitting and standing? Okay. Then I will go to the eye if, to see. Sorry, no, still in the hand. I will examine the barometer to the left. So I would like to Miss Mona to raise your hand, please, and close your
Mhm.
eye. And I think
Negative.
it is negative. Okay, then I will check one tool, the tool around the elbow, and also check the power. Check the power already. He can lift her hand, and also I will check the reflex in the biceps reflex, and I will check now the coordination. So, Mrs. Mona, can you touch my finger and try to touch your nose?
Mm-hmm.
So it
No,
is
okay. In fact.
okay. It is normal. Okay, then I go to the eye to check if there is any pallor or jaundice.
Mm-hmm. No,
The,
negative.
okay, then I wanted also to check the mouth for any central cyanosis, and then I wanted to check cranial nerve 7. Could you smile for me, Miss Mona? Okay,
Mm-hmm.
it is normal. Then I want to check the neck for any neck swelling. So I will ask from the examiner.
Neck swelling, doctor?
Yes, any neck swelling.
Mm-hmm. No
I
neck
will.
swelling.
Okay, then no neck swelling. Then I will check the neck stiffness. I want to touch your chest with your jaw, if you can, Miss Mona. So to I check now neck stiffness. Then I will go to the heart to check if there is any displaced heart, any displaced apex. Sorry, and then I want yes, I will check the tricuspid area and the pulmonary area auscultation and the aortic area auscultation, and then I will go to the
Mm-hmm.
carotid if there is any bruit in the carotid. Okay.
Mm-hmm.
Then I will go to the lower limb to check
Mm-hmm.
also the power in around the knee, and also check the reflex, knee reflex. And then I will also check if I have time. I will check the heel to knee for check the coordination, and then I will check the Babinski. Then I want to let Miss Mona, I want to see her gait, if any change in the gait.
No change.
No
Mm-hmm.
change in the gait, then I will offer, I want to end, I will ask, tell the examiner, I want to end my examination to check dipstick urine in the urine,
Mm-hmm.
and also to check the fundus examination.
Okay.
Okay. Okay. Then I will ask, I will return to Mrs. Sarah.
Mm-hmm.
Sarah, what's your concern?
Yes, doctor. Why my mother she has this confusion, got this confusion today?
Okay, Ms. Sarah, since it was the first time, so I have to exclude. I have in my list many possibilities, but most probably your mother have a condition called transient global amnesia, which is a condition for it is a sudden and temporary condition can cause some sort of confusion. It is for unknown cause. But also we have to exclude mini stroke.
So, doctor, is it serious, this condition?
I think, Ms. Sarah, I do understand your worries about your mother, but I think it is not serious.
2 minutes left.
I think it is not serious. Just we have to control her blood pressure and the blood sugar, and just that. But it is not serious condition.
Okay, so doctor, is it a stroke?
I appreciate your concern, Mrs. Sarah. I think no, it is not a stroke. But what my concerning is mini stroke because now she hasn't any weakness or tingling, so it is not a stroke. It must most probably it is mini stroke. So what we are going to do, I will involve a group of doctor like nerve doctor and yes, nerve doctor and gland doctor to see her and give her proper management.
Doctor, it can happen for her again?
I do understand your words, Mrs. Sarah, but recurrence of this condition is rarely to done, but it can happen. But
Okay.
it is rare to reoccur. Yes. Okay, do you have
Doctor, you are stopping her from the driving. So when he come back to driving?
okay, as a time being,
He can come back, I'm sorry.
yes, as a time being, Mrs. Sarah, I will involve a nerve doctor to assist her. Most probably can do scan to her brain. It is her decision. It is his decision. If we exclude mini stroke, so she can drive, and if she is confirmed she has transient global amnesia, she can drive. There's no problem about that.
Okay, thank you, doctor.
Okay, do you have any other concern, Mrs. Sarah?
No.
Okay, time is up.
Examine your questions.
Yes.
Okay.
Present your case, doctor.
Yes, today I examined Mrs. Mona. She complained of sudden confusion in the morning while she was preparing her breakfast. During taking history, she has no weakness, no loss of consciousness, just confusion. She repetitive asking the same question to her daughter, as well as she can't recognize her daughter, but he can recognize the old event. During examination, I couldn't appreciate any neurological abnormality. I check for weakness, numbness. I forget sensation. Okay, no loss of no cerebellar involvement. So my first no history of fits. So my first diagnosis will be transient global amnesia.
Okay. Anything?
Yes, the number first. Number second, maybe migraine. Maybe migraine.
Migraine?
Yes, maybe due to her migraine. She has a past history of migraine, so I should put it in my diagnosis. Number third, maybe hypoglycemia. I should exclude it. Sorry, transient ischemic attack. First, transient global amnesia. Number first. Number second, TIA, mini stroke. TIA, yes. Number three, migraine. Number four, hypoglycemia.
Any others?
Yes, maybe transient epileptic amnesia. Transient epileptic amnesia.
Okay. So what is your work for this patient?
Yes, first I will do basic investigation, CBC looking for any anemia, white blood cells looking for any high white blood cells for infection. I would like to do ASR, CRB looking for any source of infection, and electrolytes, sodium, potassium, calcium. Also fasting blood, blood hemoglobin A1C, blood sugar, yes. And also I would for transient global amnesia, it is no investigation specific to this disease. For TIE, I can do MRI. MRI. تمام. I forget to ask the patient a history of trauma. I asked, I think. Okay. And also, yes, for
Okay.
transient epileptic
Yes.
amnesia, I can do EEG for her.
Why EEG? No need. Okay, so the treatment of this patient?
Treatment, it will be by non-pharmacological patient education and counseling about her condition, and to control her risk factor, to compliant to her medication, control blood pressure, control blood pressure, and control her diabetes, and yes, and pharmacological, no specific treatment of transient global amnesia. It just reassurance and control of risk factor for transient ischemic attack. I will involve the neurologist to assess her condition. Most probably, if it is transient ischemic attack, I can do MRI. And I think CT to exclude any hemorrhage first, and then MRI for TIE.
Okay. So the treatment of TGA, transient global amnesia?
Transient global amnesia is by reassurance and control of her risk factor, like diabetes or hypertension or high lipid.
Yes, it can be risk of TIA. Okay.
Yes,
Thank
control
you,
of risk
Dr.
factor.
Muhammad.
Thanks.
Still 50 seconds, Dr. Sarah. Any other question you want to add? Okay, let's repeat the
No.
differential. Okay, I will ask him repeating the differential, Dr. Mahmoud, in order.
Yes, differential
Priority.
diagnosis.
Yes.
Yes, first transient global amnesia.
Okay.
Number 2, it is transient ischemic attack. Transient ischemic attack number 2. And number 3, yes, I put hypoglycemia, number 3. And number 4, maybe migraine.
What migraine can cause, or how the migraine can cause confusion?
I don't know.
Okay, you can say migraine-induced stroke or stroke complicated migraine, right? Some migraine can be complicated with stroke.
Yes.
However, against that, no lateralization or neurological deficit right now. The last differential you
Yes,
mentioned?
hypoglycemia and transient epileptic amnesia. Transient
Perfect,
epileptic
yes.
amnesia.
And against that?
No history of any fits or
Yes, no epilepsy.
no epilepsy.
No tremors or no shakiness or no seizure. Okay, good. Well done, Dr. Mahmoud. Let's go to the comment, Dr. Sarah and the marks.
Yes, Dr. Mahmoud, he did very well, mashallah. I think he analyzed the confusion perfectly. But he didn't measure regarding the trauma. And also regarding the diabetic, he didn't ask me regarding the complication of diabetes, if it is controlled or not. What is the last hemoglobin A1C?
Yes,
Okay.
and even I did to check
It's the
sensation.
most important. Yes. Okay. I think in the history, apart from in the examination, yeah, you didn't examine this patient. Okay, perfectly. Okay. So just regarding to assess her confusion, yeah, she's aware, yes, but we need to ask her regarding what is the time now and where you are now, and who
Yes.
this person beside you. Okay. Why you mentioned neck swelling? I didn't get you.
Thyroid.
Why in this scenario?
Because I put thyroid in any case, I take it.
No. No need in this scenario. Okay,
Yes,
neck
yes.
stiffness, yes.
Mm.
Um, yes, neck stiffness is the most important. Okay, carotid brewery. The pulse, it is most important in this patient to exclude the AF because you put TIA in your differential, okay? And the cardiovascular examination, you did it.
Yes.
Regarding the concern, yeah, you did it perfectly. Regarding the differential diagnosis, yes, transient global amnesia, TIA, we need to be excluded, and hypoglycemia, yes, it is most important, and transient epileptic amnesia. But again, is that the patient she didn't have any fits. In the migraine, just because the migraine is associated with the TGA sometimes. So no need to put hemiplegic migraine in this differential because your patient she didn't have any weakness.
Mhm.
Okay.
Mhm.
So regarding the investigation, basic investigation, we need to do CT brain to exclude or MRI brain, diffusion weight to exclude the TIA. Other, you can do lipid profile, diabetic blood sugar test. Okay, no need for EEG.
Yes.
Regarding the treatment, yes, just the treatment reassurance for TGA. If the TIA excluded, okay,
Mhm.
and control his as you told that control heart diabetes and other hypertension, hyperlipidemia. Okay, so thank you.
Yeah, thank you, Roxara. Common scenario and common topic, the confusion or the TGA. So the confusion, one of the major terms, and under this term you can find a lot of differential. So you have to have the onset, and the onset will guide you either something for the long term, so is it organ failure or something is chronic, or acute, as in our case, it would be either also something acute like trauma or hemorrhage or meningitis. It's very important to rule out meningitis in cases. They need from you to roll it out either by examination or by question. And definitely you will have the constitutional symptoms will be positive, and you will have also blurring of vision and blah blah blah. A neck stiffness, of course, you have to mention, as Dr. Mahmoud did. If you roll the meningitis, the most serious confusion in cases as acute, the meningitis or encephalitis. Otherwise, TIA, yes, you have to roll it out. TGA or stroke. Stroke mostly it will be longer than or more than 24 hours. So we are talking about this or the hypoglycemia if the patient is diabetic. Whenever you have diabetic patient, Dr. Mahmoud, at least 3 questions. Okay, what are they?
Yes. For how long you have diabetes? What's the
Okay,
medication you are on, and are you compliant? What is the last test of accumulated 3 months, which is of blood sugar.
okay, we will add 2 more. Very
Uh,
important.
yes. Any stroke before, any heart attack
So,
before,
stroke, heart attack.
any yes, any pain in the back of the heel.
Okay.
Do you have any
No, no,
fluorescent
no,
urine,
don't go more
any pain?
details. If you have uncontrolled diabetes through the hemoglobin A1C, now you can ask about the other complication. But if you have controlled diabetes, okay, if it is related to the case, you can analyze more. If not, just skip it. But don't forget the hypoglycemia. Any attacks of
Mhm.
hypoglycemia is very important in collapsed patient,
Yes.
in syncope patient, in confused patient. Any attacks of hypoglycemia will alarm you. This patient might be in hypoglycemia because he's having recurrent hypoglycemia, for example.
Mhm.
And this time he presented with hypoglycemia unawareness, for example. So it might be the case, hypoglycemia unawareness. So please, what's the medication? Since when? Any change of the dose? And the last hemoglobin A1C or the last blood sugar reading in the blood for 3 months. If you have it higher or uncontrolled, you can ask about stroke, mini stroke, heart attack, numbness, or for peripheral neuropathy, I mean. If it's lower, like 6 or 5 point, you can ask about hypoglycemic attacks, okay, or episode. And you can put as a conclusion or a differential the hypoglycemia. If not, no need, or at least anyone checked your blood sugar, particularly in the syncope. It might be the case. As we have practiced last week, the insulinoma. Okay?
Yes, Dr. Bassam.
Okay. Otherwise, the differential for your case, the question was target to the point, like what she did before and during and after. Was she repeating the questions? This is the most conclusive question for your case. If you will not ask this question, you might lose the case. So it's a case of clinical diagnosis as Parkinson, but you have to rule out the other differential, like we mentioned already. Transient epileptic amnesia or TIA, while doing the history or taking the history or while doing the examination. So you will have to rule out, or you have to rule out the other possible differential by the other steps, either by history taking or by the examination. TGA, you will not find anything right now. The patient will be resolved. It was transient, yes, by the term. So patient might be normal, or it might be TIA. The patient also will be normal, or post-epileptic or transient epileptic. This essay again. So it's a good case to have it as a surrogate. You will do all of the examination. You might not have any finding, but in the other differential, you have to do the all examination. Just to show the examiner, I rolled out everyone. The question will be target, as you said, repetitive question. Who am I, where I am, or whatever the question she is. Otherwise, you will not find anything else. But you will have the other possible differential, like lipid profile, dyslipidemia. You might have diabetes for the long term, hypothyroidism, AF, just to show you that you might have a thromboembolic event as a differential and you have to rule it out. Thyroid, it's enough to ask about it. And if you have any enlargement or you have any thyroid manifestation, you can do the examination. Why also? Because the thyroid hyperthyroidism might be AF exaggerating and the patient will have also TIA. So it's indirectly related, but not in every patient you will have to do the examination or you have to do the examination of the thyroid. Okay, so either the goiter, enlargement, or the manifestation of hyper or hypo. I think in this case, you deserve a good mark, at least all of them satisfactory. Apart from the trauma history, so in the clinical communication, but I don't think the examiner will minus you that much. So might be one examiner will give you borderline and the other will give you satisfactory. So you might get 27 or 26 minimum. You did everything in this scenario. Well done, Dr. Mahmoud.
Thank you, Dr. Bassam. Thank
Any
you, Dr. Sarah.
question? Any question, Dr. Mahmoud, Dr. Sarah?
Thank you, Dr. Bassam.
No, Dr. Bassam, thank you.
Okay, now we'll open the discussion. Anyone want to comment? Before anyone will comment, Dr. Nada, I share the photo. She's right. Normal pressure hydrocephalus, although it's not common to present with Parkinson, but it's one of the possibility to have a Parkinson feature with normal pressure hydrocephalus, along with the other triad we mentioned earlier. The patient will have dementia, abnormal gait, and the urinary incontinence. Okay. Thank you, Dr. Nada, for reminding. And always not to only write, you can even speak and express your talk. Whenever you have something to share, try to express it. Okay, Dr. Nada, thank you again. I share the photo down. You can see in the chat box about the normal pressure hydrocephalus as a cause of Parkinson. Okay, there is a big discussion about masked hypoglycemia due to beta blocker. In conclusion, I heard it before from the consultant. Just read about it now. It's to ensure the information the opposite of my previous. So the beta blocker masked the sympathetic symptom of hypoglycemia as tremors, palpitation, sweating. So patient lost the awareness of hypoglycemia at this level, so he may be go directly to CNS symptoms as confusion, convulsion, so on, without alarming sign. Yes, it's one of the topic in the communication scenario. Whenever the patient on beta blocker, he might be presenting with awareness, sorry, hypoglycemia and awareness. So you have to screen any drug or medication you are on because it might be the cause of his hypoglycemia and awareness. Okay, one of them, the beta blocker, alcohol, because of autonomic neuropathy, and the diet control, the exercise, excessive exercise, the insulin. Okay, so you have to do screening. Beta blocker, one of the causes, by the way. Thank you for this side discussion. The other differential, Dr. Nada, TGA, TIA, complex migraine. Okay, but I don't know, migraine can cause confusion apart from the one we mentioned as TGA association. I think it can present only with aura, headache, flashes of light, but it will lead to confusion. I'm not sure. Anyone has any information? Yeah, Dr. Nada again, thank you. Could be a risk factor, yes, exactly, but not as direct. Thank you, Dr. Nada.
Yes,
Delirium,
I think
yes.
Dr. Basim, yes, complex migraine, the case come before in Egypt. It was only monoparesis. One hand only has weakness.
So we are talking about weakness, not confusion.
Yes, I think Dr. Sarah means that TGE associated more
Yes, yes.
with migraine.
Yes, it is like that. Yes, it is
Yes.
like association, not as
Not as a
as
cause. Yes.
a cause. Yes. The other thing, the migraine itself might cause all brainstem aura or vomiting or weakness, a flash of light. Okay, but it will not cause confusion unless it's complicated by stroke. If the patient, for example, on streptan, so it or OCP, so it might be like a complication, not as the migraine per se.
Yes, doctor. Yes, Dr. Basim.
Okay. The other comment, there is also ataxic migraine. Yes, so brainstem or cerebellar. Perfect. Yeah, very active today, Dr. Nada. You deserve a gift. Okay, another. Yes, I think these are the differential. Dr. Nada, complex TIA, TGA, iPhone, delirium, electrolyte disturbance. This differential for the major term of confusion. Delirium in elderly patient, post-infection, hyperglycemia, all metabolic disturbance, all electrolyte disturbance. So it's not confined to one only. But whenever the case or the scenario will take you to a narrow differential, now you can put your differential according to the diagnosis. Drug induced, yes, definitely. But don't forget, please, everyone, roll out the most serious one. And it will be positive in the constitution. So the patient will present with fever, high grade fever, or the other loss of weight, loss of appetite. Yeah, I'm talking about meningitis, TB, whatever the cause of meningitis, but it could be your case. And if you will not roll it out, they will minus you in the clinical judgment in the differential. Okay, don't put it as differential, but you have to roll it out because it's not matching the meningitis in our case today. But one question you will show the examiner that I'm asking about the most serious, not only the meningitis or the confusion, every complaint. You have to put the most serious differential in your paper before going inside and ask one question even to the target regarding this differential. For example, acute chest pain. I have to ask about typical chest pain, the nature. I rolled out MI. Okay, I'm okay now. Pneumothorax, PE, all the things while you are screening, you have to roll them out. It might be the very simple case like myositis, but I should roll out the most serious This is how to play the game. Roll out the most serious and conclude the most sensible differential. Okay. Anyone want to add any comment?
Yes, Dr. Bassem, regarding the investigation that should be requested, usually the monitors or if we are attending courses, they usually give us a list like basic investigation, inflammatory marker. Like Dr. Mahmoud, he told ESR, for example. On my previous exam, my case was also acute confusion state, and I mentioned ESR, like Dr. Mahmoud. She was very angry,
Oh
and
my God.
she was very angry. Why ESR? I told her maybe to exclude, to rule out infection. She told me, you ask about fever, you ask about neck stiffness. It was
Yes.
you
Oh
ask.
my God.
So I mean, sometime I think we should select maybe
Yes, you're right.
we should select the target investigation.
Yes.
Especially that the case you get me was the same exactly. So
TGA دكتورة مروة TGA also
not PGA. She was on the feedback. It was written that it's acute confusion state in the feedback.
yes this
Uh,
case was in المعادي yes
no, it was in Alexandria. But during the exam, while I was taking a history, it was memory loss started 7 months ago. But maybe that this is maybe it missed from me because one of the doctor I was discussing with him that they put for me in the feedback that I should mention stroke, not vascular dementia. He told me maybe you didn't ask about the deterioration. Maybe the memory loss started 7 months ago, but then maybe she was more deteriorating in the last few days. So you will put the acute causes, and this is maybe it was memory loss started 7 months ago, but maybe the converted to acute confusion state and acute stroke. So they put for me in the feedback why she mentioned vascular dementia and you didn't mention stroke, acute stroke.
Okay, so do you need acute differential of acute, not as a as a cause?
Confusion for how long, Doctor?
The main complaint was memory loss started 7 months ago. Okay, so I started to ask about the memory, the recent, the remote memory, everything about memory, and then I put along a list of differential. One of them that because the patient was diabetic hypertensive, I put vascular dementia because there was no lateralization sign or no neurological deficit at the time of examination. The patient was hypothyroidism and she is forgetting to take her medication due to her memory loss in the last few months.
All of this is for
So
dementia.
I put severe hypothyroidism, but in the feedback they mentioned that the condition not memory is acute confusion state, and on the feedback also that I should put not vascular dementia to put stroke.
You are asked regarding the confusion or not?
I asked about the
The
details.
memory.
Confusion by name. Yeah, apart from the memory, I think.
I asked about no, I cannot remember now, but I
Yeah,
asked
Yeah, that is why. Yeah, sometimes yeah.
the details of memory and the neurological symptoms or symptoms that there is any weakness, any unsteadiness like that, all neurological symptoms. So I think one of the doctors, he told me maybe didn't ask about the deterioration in the last few days, that the memory lost 7 months ago, but maybe she is deteriorated in the last few days.
Yes.
Yeah. So
Or associated with confusion. It's,
although,
yes,
although the complaint was memory, but the need from you to speak about the acute thing. I don't know
yes.
how. It doesn't make sense actually to give a
No.
complaint of something chronic and you need from me to give you the differential of
to
acute.
bring to the acute, yes.
Yes, and also that at that time I bought also she told me it is the same examiner that she was very angry about ESR, so I mentioned it.
Okay,
She was very
okay.
very angry, and the other thing also she asked me. I forget to ask about the mood, and this lady she lost her husband. And after that, the memory started to be deteriorated. Then she told me that maybe psychological.
Mm.
I told her yes. So maybe psychogenic amnesia from the differential, but I don't know. They told me, they mentioned for me the causes of chronic causes, but
Yeah.
they want me to exclude the acute.
Sometimes they are unfair, by the way, Dr. Marwa. Again, it depends on the center and the examiner, but unfair to give you or to minus you because they need something to ask and to get it from you. If you didn't do, they will minus you. Okay, let's go with the ESR, for example. What the problem if I will do ESR to patient with acute confusion state, even I want to roll out the encephalitis, for example. It's one of the
Yes,
acute
I told her
differential.
like that. She told me
Okay,
that
there
the
is
different
no neck
from
stiffness. I agree. Might
yes.
be the patient receive antibiotics and now he's partially treated. For example, we are just discussing what the problem if I mention ESR just to rule out infection. You are talking about major term of acute confusion state. One of them, as I said earlier, and the most serious is encephalitis, meningitis. I should roll them out. What the problem if I add ESR? And this is basic test to be done in every admission. I will admit this patient definitely. I should roll out or yes, no fever, but might be the patient receive antibiotic, oral antibiotic at home. What the problem if he will be present with mild asymptomatic or mild symptomatic?
And even
So
for even infection on old age can lead to acute confusion state. So ESR also has a rule, even if not meningitis or encephalitis. Many patients with acute UTI may be confused.
yes, perfect. This is one of the
Yes,
cause post infection I mentioned.
yes.
That's why
I
I
think
said it's
she was
unfair.
very angry. Yes, she was very angry, really, and even they mentioned for me in the feedback that
What center, doctor? Which center?
Alexander.
I
Yes,
think the examiner was
Area?
having
yes, Alex. Yeah.
Alexander.
Hmm.
The examiner was having psychogenic issue, not
I should look
the
at
patient.
Yes, I
that
know.
one is
I know this
confusing.
Really?
Dr. Marwa. This doctor was
Yes.
the short one and has glasses in his eye. Yes.
The doctor? No.
Yes.
She was from England.
Korean.
This
The
old
Indian
age,
one?
old
Yes.
age.
The
Yes,
tall one. The tall one.
yes,
The old age
yes,
one.
yes,
Yes.
yes,
Yes.
yes. She is. Yes, she is the one. Yes,
Oh,
really, she was
yes. Yes.
very angry. She is took a long time to speak to me and arguing with me for the ESR.
Yes.
Then I
This
got
doctor give this doctor last time in yes in قصر العيني give me his stethoscope. Tell me listen to by my stethoscope. I told him
And
in the cardio yes, in the cardio station, there is a man, Dr. Basim. The patient was has abdominal mass, very abdominal mass. Just I enter the station. He told me not move the patient, not to the left, not to just in the bed. So I examined the patient. The patient was has abdominal mass pressing on his heart. So I listen to the heart. I listen. It is pansystolic murmur in the mitral or in the tricuspid. So I told him I listen to pansystolic murmur, maybe mitral regage or tricuspid regage. I can't be sure. So he gave me his stethoscope. Okay, listen well, doctor. In the examiner question, I gave him stethoscope. I told him, yes, doctor, it is pansystolic murmur, but I don't know really. I can't appreciate it is mitral or tricuspid. He told me, okay, what is the if the patient has mitral regurg, what will could be? Tell him that maybe pulmonary congestion, but I can't move the patient to listen to his back. Okay, and they said to me, okay, what if tricuspid regurg? I told him maybe there is GVP increased. And then he tell me, okay, what's your diagnosis? Tell me MR or TR. I told him, so doctor, it will be MR. Just that is the question. And he tell me, okay, doctor, thank you very much. In the feedback, yes, it is MR, but I lost communication and the clinical judgment and everything and the diagnosis.
this is a long case, right? Long clinical?
No, doctor, this is short clinical, short clinical.
Short, but no clinical communication in the short. So you lost
In
the
all
differential,
skills,
yeah, it's differential
yes,
and physical examination,
and
for
the physical
example.
story, and the clinical judgment.
Okay.
Although
Again,
I tell him mitral regurg
yeah,
because the
it's
patient Dr. Basim was in the bed. He told me
yeah, yeah.
don't move the patient, don't listen to the back, don't listen, don't
Okay, but
sit the patient.
adding to the technique, but you can know from the radiation to the axilla, for example. This is MR. Did you do the
Yes,
axilla radiation?
yes, I do, Dr. Basim, but the patient was very thin, has abdominal mass. I
Yeah,
can't
okay.
يعني very hard
Yes, yes.
to the patient.
Let's forget about the past, all of you, and focus on the coming. Hopefully, inshallah, it will be easier and better than the
Inshallah.
previous. Hopefully, yes.
Inshallah.
Because I know it's whenever you remember, you will be again in trauma. We don't need it right now. We need to be as a positive, thinking about I will do it, inshallah.
Yes, Dr. Basim.
Okay.
Inshallah.
Okay, thank you, Dr. Marwa, for your experience. You want to add anything? But if they ask again about the confusion in elderly, it's one of the possibility encephalitis still, even if the patient is not having neck stiffness. I should
Yes,
do the
yes,
inflammatory
Dr.
markers.
The point, Dr. Bassem, that I said maybe we should, if we mention some investigation, we should be
Yes,
more specific. I don't know. This is,
you are absolutely right. If the
um,
patient is straightforward to something which is clinical diagnosis, like our case today, TGA, no need for ESR. Definitely, no need to do even the image. Select the image to do. If you want to roll out TIA, don't tell me I will do CT brain because the symptoms resolved. If I said CT, I will be wrong. So choose and select. Don't waste the resources. They need that to be to the target and what the investigation you should do and what is investigation you shouldn't do or involve in your steps. Yeah, try to speak and take a breath before mentioning the investigation, particularly those with clinical diagnosis. Okay, our patient today will not have anything apart from investigation of the cause or the comorbidity, the diabetes, dyslipidemia, lipid profile, thyroid function if I suspect, but
yes,
be
Dr.
more selective. Yes.
Yes, for that, yes, I told Dr. Mahmoud because maybe his case straightforward. يعني. For me, it
Yes,
was
yes.
يعني general differential
I
diagnosis.
agree. I
Yes,
agree
yes.
with you. Yes, they get very nice information to the target again. You have to select, don't do unnecessary investigation. They focus on this thing whenever you are talking about. But again, it depends on the examiner. So some examiner will pass it. What's the problem? I will do SR. If I mention the specific, sure, so she will accept the general. But if I will do everything for no reason, that time she can judge why he mentioned everything. Okay. But our case today, for example, I should roll out TIA. TIA is a major pathology. I have to roll out the all comorbidity in the case. As a AF, echo, ECG, all the things can be the TIA and one of my differential TIA. So no one can judge or minus whenever I search for those comorbidities. Okay. Inflammatory markers might be also no need in this scenario because why I suspect an infection if nothing can give me infection in this scenario. Okay. But yeah, we have to think before answering. Choose and select the most important investigation you have to do. Coagulation profile, for example, is very important here. If, for example, I suspect a hypercoagulable state or something related to, again, to the AF or whatever. Okay. Any question? And thank you, Dr. Mama. Again, anyone want to add?
Dr. Basim, I have a concern.
Yes, sure, Dr.
This
Shukr.
this last patient with a confusional state, if I heard very well, I thought the surrogate said the patient regained full consciousness. If I heard very well, that the patient was now normal, no more confusion or any other abnormality for that matter. And then, so if that is the case, I was wondering now, without intervention, she gained full consciousness. So the other differentials, will it be necessary to add them as differentials, like like hypoglycemia and the other differential that even without intervention, the patient gained full consciousness. That is, if that is what is the case. I'm just wondering, is it maybe before the history thing? Yes, those ones can come as differentials, but after the history and physical examination, I was wondering, should we mention them as differentials, given the fact, particularly for hypoglycemia, for instance, that the patient gained full consciousness without any intervention?
Yeah, you're right. But why I am saying hypoglycemia in this patient? What do
Hmm.
you think? Because of his diabetes.
Ah, okay,
Yeah, so I should
okay,
put it in my and I should do the investigation to know, and I should ask about anyone checked your blood sugar because it could be the reason and it might be the case. Okay.
okay.
Although
Yeah,
it's,
I
yes,
agree.
as you
I
said,
agree.
it was regained by his own or by its own,
Mm,
but still,
mm,
he is diabetic. He has risk to have either hypoglycemia or hyperglycemia complication. If I don't have the diabetes, yeah, I can
mm.
remove it from my definition. But they will put
Okay,
it,
so
yeah,
we can still add as differential.
yes,
Huh?
of course, definitely. With
Okay.
any diabetic patient, put the hypoglycemia one of the definition, not only hyperglycemia, because hyperglycemia can lead to coma, right?
Mm, okay, okay. It's okay. That's just my concern. And then the second one is the last person that spoke regarding ASR. I'm just wondering, is it in a way to circumvent this kind of problem? Is it man, or is it, will it be okay to mention different sorry, mention investigations and give reason? And but again, I thought it would be wasting your time. Maybe for instance, mention complete blood count because you are looking for evidence of infection. You want to know the patient's anemia. You mention liver function test. You want to look at the liver enzymes and all of that. Will that take care of this kind of problem?
Yeah, listen, I will give you advice. If you feel the examiner
Mm.
feel angry, this is general advice.
Ah,
Okay,
mm,
say, oh, sorry, sir, and change it. If he said, yeah,
ah,
so don't argue with the examiner. Why? The argument will lead to more argument, and he will not ask more, and he will not judge you on more information. He just arguing with you. He will just
okay.
argue till the end of the discussion. Why you put this?
Mm,
Because I have, for example, possibility. Don't try to convince him. If you see he is like angry because of the answer, you can say,
mm,
okay, doctor, we can skip it. We can do other tests. At least don't argue with him. Okay.
okay, okay,
Yes,
okay.
it's a major, and every patient coming to the hospital, we are doing all these tests: liver function, kidney
Mm,
function. What the problem if you do? I
yes.
didn't say I will do autoimmune profile. How you can judge me on ASR? It's one of the major and basic baseline investigation. I can do it in on any admission. What the problem? If he you
Mm,
felt he is
okay,
angry and he want to argue with you, okay, withdraw and continue your answer. Or you can say
okay.
another answer which can impress him, like doing echo doctor bedside, and try to be more systematic while answering. Don't give a lot of investigation without arranging them, like saying CBC, electrolyte, kidney function. What are they? This is general, okay? A specific. I should do some specific, like what doctor? He will be impressed whenever you are saying, yes, I will do specific. What do you think the specific here? I will say lipid profile, hemoglobin A1C, blood sugar, fasting. Why you want to roll out the underlying pathology? Anything else, Dr. Echo, AF, ECG, because I suspect AF related. Okay, so you have to give him the reason and the rationale of your investigation. Yes, some tests are general, and I'm doing them as routine, but there is also tests I should start to mention to the examiner, although I will not start doing them in the patient investigation. You got it?
Okay. Yeah, yeah.
Yeah. But
Okay.
it's a matter of showing the examiner yet that you are systematic and organized, not just giving the whole investigation for any patient. This is clinically and practical wise wrong. Nowadays, anyone want to investigate, he will give you a lot of investigation without rationale. But you have to put rationale. I want to do autoimmune profile. Why? I suspect vasculitis. Okay. But I will not say for this case I will do vasculitis workup. Correct? So it's
Yeah.
a matter of convincing without argument. If you feel he's angry, forget it and try to skip to another point.
Thank you.
Okay,
Thank you.
thank you. Thank you, Dr. Gabriel. Any other question? Anyone want to ask? Dr. Nada also wrote here, in elderly patient, normal temperature cannot exclude confusion due to sepsis or infection. I agree with her and Dr. Nada, I mean. Yes, you have to rule out infection even with confusion in elderly patients. They are very sensitive to this infection and they can respond to the infection by confusion. That's it. Okay, so roll it out. The constitutional questions is very important in every scenario. Don't miss the constitution. It might be the case and it will show the examiner that you are rolling out something serious. If you roll it out, forget about them. Okay, like fever and neck stiffness in our case, I asked and I found it's negative. Forget about it. I just show the examiner that I ask about meningitis. If he ask in the discussion, did you ask? Yes, I asked about fever, neck stiffness. He cannot say no because you already asked. Okay, so he can judge on this question only without even mentioning the differential of meningitis, and no need to mention meningitis. No need to say this is could be meningitis case. Okay, as a differential. Okay, thank you. Nice discussion, nice cases. Thank you, Dr. Sarah and Dr. Mahmoud. Thank you, everyone. It was very informative, interactive one. Thank you, Dr. Nada, for your information, sharing the information. Thank you, Dr. Marwa, also for your experience. Thank you, everyone. Thank you, Dr. Gabriel, for your questions. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa rahmatullahi wa barakatuh. Thanks, Dr. Bess.
Most welcome.